Friends of the Retina Channel podcast, welcome to episode 73 of this series. I'm Kivan Kushan, your host from Toronto, and today we have Dr. Landon Rohowetz from Bascom Palmer Eye Institute, who is going to talk to us about a nice study that he put together with the rest of his team at Bascom Palmer on retinal detachment associated with retinal dialysis. It's a retrospective study spanning about 10 years, and patients presented to their institution and had RD associated with dialysis. And then Dr. Rohowetz is a resident at Bascom Palmer Eye Institute. He is described by Dr. Sridhar, who is the host of the Straight from the Cutter's Mouth podcast, as the star resident. And I'm happy that Jay put us together, and we have this recording for you. And I enjoyed chatting with Landon and learned from him, and I wish him all the best in his endeavors. Without further ado, let's start the conversation. Hello.
Hi, Dr. Kushan. How are you?
I'm good, Dr. Rohowetz. How are you?
Good. Thank you so much for having me.
It's a pleasure to have you. Thank you for coming on the show.
Thank you.
So I imagine the resident on-call schedule or clinic is done tonight.
Yeah. I got off about half an hour ago, so I think we're in the clear.
I remember those days. So well, that's excellent. So Landon, thank you very much for coming on the show. You might have listened to previous episodes of this podcast. Now we have the video version of it. You're the third guest that has a video on. So that's great. We're going to talk about the article that you published. You're the first author of this study from Bascom Palmer Group. Dr. Flynn is the principal investigator, and I'm going to thank our friend Dr. Sridhar, Jay, who connected the two of us. And he said you're the star resident, so to put this project together. So congratulations.
Thank you.
So this, just for the listeners and the viewers, I'm going to tell what this was about. This is a retrospective study, essentially. You looked at the RD cases in your institution in Miami who were associated with retinal dialysis. And you essentially characterize them and see what patient population they're involved in, what treatments were done for them, and what the success rates were. And try to give us some kind of a literature overview of who are these people who come in with retinal dialysis and RD. If that's okay with you, I'll open the floor for you and go ahead and tell us who you enrolled and how you how did you dig up the study, and so many people, what kind of system you have to find these patients, and take it from there.
Yeah. So we got interested in doing this study. Just seeing a patient in the clinic spurred our interest, because retinal dialysis is not rare, but not necessarily common, especially to be diagnosed necessarily during the fundoscopic exam. So we thought it'd be a good idea to look at all of our cases in the last 10 years and try to gain some insight and provide some valuable findings with regards to the correct treatment of retinal detachment associated with retinal dialysis. So we decided to look through a chart review. So we used an EMR. We identified patients either by CPT codes and or keyword searches. So we searched retinal dialysis of all patients who had been seen at Bascom Palmer in the last 10 years, and a couple other keyword searches. And we got back, a good amount of patients, probably 300 or 500, 300 to 500 patients. And we went through and we ended up having about 60 patients, 60 eyes of 58 patients with retinal dialysis associated with retinal detachment. And so
I imagine it's the same EMR you guys used for 10 years. It's good you didn't change it, or you maybe switched over.
Yeah, so we actually switched from paper to EMR around May of 2014. So some of the cases had to be identified with paper charts, which we have uploaded into the system, which makes it easier.
Wonderful. So you mentioned you had 60 eyes of 58 patients, and you characterized them, so tell us about them, please.
Yeah, so the majority of eyes were in males. So about 80% of eyes, the retinal detachment occurred in males. And there was a majority of males in both traumatic and non-traumatic eyes. About 60 or so % of cases were associated with trauma. The split between macula involving and non-macula involving was pretty equal. And those are the majority of the kind of descriptive variables that we measured. The macula involving patients had overall worse visual acuity compared to the macula sparing patients, as can be expected. The most common mechanisms in patients with a history of trauma were like an altercation, being hit with a fist, and then basketball injury was common, followed by metal blunt trauma, and then elastic bands.
So it makes sense, I guess, males get involved more in these activities. So that makes sense that way.
But it is interesting because there's still a male predominance in patients without any
that's interesting.
History of trauma. So, and that's pretty consistent across studies, including this one.
Interesting. So even can it be because of some trauma they don't remember, or?
I think that's the leading theory is, there probably is some, trauma that just happened before. And, these are slow progressing retinal detachments generally. They're chronic, often associated with pigmentation lines. And so, it may have been there for a while, just that it wasn't diagnosed.
Who knows what I did to my eyes when I was a kid, so I don't remember. Not many good things. All right. So that's the patient population. And then you looked at the treatment modality. Could you tell us about those, please?
Yeah, so the majority of patients, so about 82% of patients underwent a primary buccal only. 11 patients had, or about 18% of patients had a buccal with a vitrectomy. And so, the most common reasons for doing a vitrectomy in addition to scleral buccal were PVR, vitreous hemorrhage, macular hole, traumatic cataract. And so there was, like I said, the majority underwent a buccal only, but there were a good amount of patients who underwent a vitrectomy as well. And so that gave us the opportunity, to compare the results between those two treatment modalities.
And what did you find?
Yeah, so the primary measurements that we looked at, the main outcome measures, were visual acuity at last follow-up. So all patients followed up at least 2 months. And then the rate of single operation success at 6 months. And so visual acuity wise, the visual acuity was, it was worse in patients at baseline. So when they initially came and presented to Bascom Palmer, the visual acuity was worse in patients who underwent vitrectomy. So, that's an important point. And we took that into account. So when we did the analysis, looking at the final visual acuity and comparing it between the two treatment modalities, we took into account the fact that the visual acuity was worse at baseline in the vitrectomy group. And despite that, we still found that the visual acuity at the last follow-up in patients who underwent buccal only was better in patients, was better compared to patients who underwent a buccal with a vitrectomy.
So you think some kind of less favorable final vision was because of the vitrectomy component, or could it still be because they started out worse?
It's hard to say, for sure. Like I said, we tried to take into account that, but every case is unique, and so there may be a component of that, but at least there was some sort of signal that patients who underwent a buccal only had better visual acuity outcomes.
And they had the cataract, I guess. Some of them they had cataract as a result of vitrectomy.
Yeah.
Okay.
And then we looked at single operation success, and it was about equal between the two treatment modality groups. So buccal vitrectomy had about 78% single operation success at 6 months, while the buccal only group had about, say, 77% single operation success rate. But it's important to note that about or 5 of 9 eyes at the 6-month point still had silicone oil in place. So we have to take the reattachment or attachment rates with a grain of salt, because they did have the silicone oil tamponade still in place.
Did you get a chance to look at the longer term outcomes, like when they had a second or third operations, or they had silicone oil removal? Did you have that information? It's hard in retrospective studies, but
yeah, we didn't look at specifically at like patients who had silicone oil removed or anything like that. We tried to keep it relatively simple for this paper, with concepts that are pretty straightforward.
And follow-ups, I'm sure, is kind of patchy for some patients, so you can't do.
It ranged between 10 years and 2-3 months. So
okay. So I guess from what you have, we can kind of say that primary buccal may be just as good or maybe even better than the buccal vitrectomy for these retinal dialysis causing RDs. Does that make sense?
Yeah, I think that's our main point that we hope to get across, is that vitrectomy is obviously becoming more popular, and scleral buccals are correspondingly becoming less popular, but we think there's still a definite role for scleral buccals alone, particularly when a retinal dialysis is confirmed on exam, and especially useful in these young patients who don't want to have to have another cataract surgery or another surgery for cataract, and don't want to have to undergo positioning or what be it.
Yeah, for sure. That's great. So just to summarize, these are primarily males, and you said 80% males.
Yeah, 80%.
But 60% of all comers were trauma associated. And even non-trauma associated, which is the remaining 40%, was still males dominated. And then a majority got a primary buccal for treatment, and they did just as well, or maybe even better than buccal vitrectomy patients. Wonderful. Anything you want to add, Dr. Rohowetz? Anything that you want to take home message that we kind of missed it you want to add to the discussion?
One thing, one other point we tried to stress is that all of the patients in the vitrectomy group developed a cataract or required cataract surgery, and only about 15% of those in the buccal only group developed a cataract. So it kind of reinforces the fact that you can really avoid usually a second surgery in these patients by just doing a straight buccal. I think it's just really trying to reinforce the fact that less is more when it's possible and safe. And if there is a redetachment or anything like that, patients can undergo an additional procedure if it's necessary.
Yeah, I guess the problem with buccals is that fewer are being done, so fellows don't learn them as much. So it's becoming a lost art slowly,
Yeah.
But hopefully not.
Yeah, we're definitely pro scleral buccals here.
That's wonderful. Well, thank you, Landon. Thank you for coming on the podcast, and thank you for putting out this great paper and with your group. And I wish you all the best in your future endeavors and more publications and next stages of your career.
No problem. Thank you so much for having me, Dr. Kushan. I really enjoy your podcast. Love listening to it, and it's an honor to be on the podcast.
It's a pleasure to have you, man. Take care. That wraps up episode 73 of the Retinal Channel podcast. I hope you enjoyed it. I hope you learned from it. I certainly enjoyed talking to Landon and also learned from him. And as you may know, the podcast is also broadcast in a video format. If you're listening to this recording, please do know that it's also available on YouTube now. You can go to YouTube and search the Retina Channel podcast. And then you can watch the recording and you can watch the presenters and the authors who talk about their study. I think it's a nice addition to the series. Of course, we're still going to be publishing everything in audio format as well. Well, just a bit of a giveaway for our next episode. My guest next time will be Dr. John Park, who is a new staff ophthalmologist at Toronto Retina Institute, and he's going to be talking about one of his new publications and new research endeavors, and I look forward to that conversation with John. Until then, take care and be well. Bye-bye.